Hello and welcome. I'd like to welcome everyone to our next episode of Complex Case Discussion Series. I'm Dr. Ryan Kazemi, and it's a pleasure having all of you with us. This is a live webinar, as you're all familiar, and of course we will have it in a recorded format and posted on our website at facialartdentalforum.com. Today, with me, I have one of my good friends who will be our expert panelist, and I'd like to make the introduction, Dr. Hugo Bonilla, and he's a prosthodontist in Annandale, Virginia. We've known each other for, I want to say, over 20 years.
Since 2001.
Yeah, I think
we founded
early days.
Millennium.
We had started an educational study club back in the days with a group of other colleagues at the Millennium. We lectured many times together. We've talked about many cases together. And it's really a pleasure to see you again.
No, thank you very much for the opportunity. It's always a pleasure to be with you, always a good friend, a fantastic surgeon. And I'm always fascinated by all the technology and how you are able to provide your knowledge and share your knowledge by social media in this environment. So thank you.
Thank you very much. Appreciate it. Appreciate it. Now, we're both solo practitioners. So what that means is that when we have patients come and see us, a lot of times we have to think on our own feet and really don't have that opportunity to interact maybe with others. But I think it's been great to be able to share our cases, especially these complex cases, where we can kind of have a team approach and still be able to look at some of these very difficult cases and be able to learn from each other and understand what approach we're going to take, what are the treatment plans, what are the challenges. By the technology and doing Zooms and online meetings, this has become much easier. So it's an entirely different way to practice, and it's great to have that.
Yes, makes the distance a lot closer and the sharing of knowledge so much simpler. When we started with Hamid, I remember that we were into getting the fancy digital VCRs, recording surgeries, recording procedures, trying to communicate. I remember that taking intraoral photography was something basic, and then became an everyday situation to do with our patients, to share knowledge. And now when we can share a patient photo and we are both on the internet, seeing the case, seeing the radiograph, doing a brainstorm makes just such a big difference.
It's a huge difference. So let's talk about this case. Today's complex case discussion series, which I call the perfect storm for a full arch treatment failure, is a patient that we have collaborated together to some degree, and I'll explain that in just a moment. And again, our panel between myself and Hugo, we hope to dissect this case and be able to share this with our audience. Let's give the patient history. This is a patient that came to me initially having just received 6 upper dental implants and an immediate restoration, a full arch immediate restoration that was placed abroad. About 6 weeks later, he started to experience pain and swelling around pretty much all the implants. He reported some minor bleeding from the gingival tissues. And also he started to notice that the entire restoration was becoming gradually mobile. Here's a Panorex which showed 6 upper implants, a full arch restoration that looks like a zirconia, perhaps, or a metal under casting. Can you tell?
Kind of difficult to tell, especially because of the ceramics, but probably it looks like it's zirconia. Okay. Difficult to tell on the back, probably some layered porcelain on the back, but appeared that it's zirconia.
Yeah. And what I could see on the Panorex was some bone loss on the distal implants that were quite evident, but really difficult to see on the Panorex. So we take a CBCT, of course, and I think that's probably the first imaging that we need to really understand what is happening with any existing implant that may be undergoing peri-implantitis or bone loss. And so from the CBCT, we could gather that yes, there are 6 upper implants, and there was notable bone loss on the distal implants. We can actually see that quite well from this view. But then we go to the cross sections of the cone beam CT scan, and let's go through this. Implant number 5, we can see there is extensive bone loss on the buccal aspect. Number 6, the implant is somewhat sitting in air. There's not much around it, and there is this unusual radial opacity on the buccal side, which seems to be away from the implant. Number 7 is a mini implant, what it appears to be, and also some radial opacity, what appears to be some sort of a bone graft. Number 10, another mini implant with some bone material. Number 11, same thing, not much bone covering on the buccal. And number 13, also complete loss of bone on the buccal aspect as well as the periapical aspect. Close to being a sinus perforation, but not quite yet. So this patient comes to us with a loose restoration 6 weeks after it was completely placed. And has pain, has swelling,
mobility,
and mobility, and the implants look as such. What are your thoughts?
Well, first, that was a sad trip because things like this sadly look like they were made in a hurry without considering all the bone morphology, volume, length, and it's sad even when you see the bone fragments on buccal for all remaining apparent bone. It's like they broke and they are in the air. It looks like they are not even connected to any surrounding bone. The very aggressive threads on the anterior implants. You can see the cement connecting probably the abutments to the prosthesis. However, it doesn't even look like you have even abutments in there.
Right.
Sadly, it just is a sad situation for the patient.
Yeah, so obviously he's in distress. I think the treatment considerations from a first step is obviously managing his infection. The first thing we did was place him on antibiotics, and this restoration was so loose that we knew it was going to come out relatively soon. So we prepared him for just a removal of the restoration itself. The implants themselves, I was not sure whether or not they're integrated, some of them or not. I thought maybe some of the abutments or the superstructure was loose, or perhaps the implant itself, really difficult to tell. So we had this conversation, and we scheduled him fairly immediately after this visit to remove, debride, clean, at least get him out of the immediate infection and pain that he was suffering. But let's kind of talk about this a little bit. I want to give you a little bit more history about the nature of this treatment that was done. So I asked him the history of the treatment. So he went abroad. Apparently from his report, the implants were all placed. There was an immediate load protocol that was done with the prostheses that you see. There was no transitional. This was actually the final restoration and prosthesis that was delivered. And also there was some immediate bone grafting. So there was implants, bone grafting, and immediate load protocol with a final restoration in place, which is very difficult to imagine how that's done. But the reason that we know that that was the case is because he was there really for about a week, had the procedure done, had this placed, and then he was told, you're good to go. And he came back to US. So there was really no time from standpoint of his first day there to when he came back to really have a transitional restoration prepared and also a final. It was really all in one. Apparently there was a cone beam CT scan, but there was no other digital workup that was done. Again, no surgical guide and things because of the time limit that he was there. So I think, when we look at this case as a total failure, and I call it the perfect storm for failure, the perfect storm, and these are all the things that altogether, I think, led to the condition that he was experiencing. Obviously, it was inadequate bone. We can see that there was atrophy of the posterior maxilla. Certainly, there's atrophy and horizontal inadequacy in the anterior. Single-stage implant and bone grafting. This was all done in one stage, which is risky, especially with this amount of bone grafting. Poor implant selection. I couldn't really understand the rationale for doing a mini implant and a conventional implant, except the fact that there was inadequate bone, and so the mini implant was selected as an option. This was a free-handed implant placement. It was not guided. The implants had really no primary stability. They were somewhat placed outside of the maxillary envelope because there was just no bone there. Now, some of that bone loss may have been the result of the infection, but they were very poor primary stability. The bone graft that was done, interestingly enough, and we saw that in the CT scan earlier, was kind of somewhat placed outside of the maxilla and the implants. So what I gathered is that there was some sort of a tunneling technique that was done where the bone graft was placed, but it was placed supraperiosteally. And that's why we see this space between the implant and the bone graft material. There was an immediate load without a proper implant support. The prosthesis was cemented to the implants. It wasn't a screw-retained restoration. And there was significant residual cement, which I'll show you in just a moment. And of course, just the inadequate support with the type of implants we had. So I call this a perfect storm because if you want to have a failure, you have to line up all these things and do it right. And this is how you end up with a perfect storm.
Yeah. On top of that,
on top of that, the mandibular arch, I was able to restore later on the mandibular anterior teeth, but the occlusal plane is uneven. And if we add that to the perfect storm, now we're even making things worse because on top of doing an immediate loading with a very heavy prosthesis, which is a zirconia prosthesis, on top of that, in unstable implants, bone and grafted areas, and on top of that, you add that it's a very uneven occlusal plane. Mm-hmm. The forces are going everywhere. There's no controlling how he bites and where he bites. Right.
It's a problem.
So it's perhaps an occlusal overload on top of the unsupported implants. Mm-hmm. So the treatment strategy, the question is, what can we do at this point? I think the treatment strategy in a case like this, it has to be stage approach. Mm-hmm. One of the things I've learned over the years about managing any type of complication is it's a time to actually slow down because of a patient who's already has experienced an emotional loss, a financial loss, and a bone loss in that sense that we really need to slow down and not only to reassure the patient about what can be done in the future, but also from standpoint of biological standpoint for us to be able to regain what has been lost in a very slow, methodical way. So the first phase of this treatment strategy is really no mystery. We have to debride, clean, resolve the infection. The implants are all infected and needs to be removed. The second phase, we can sort of think about how to reconstruct. We know that we're going to have a lot of deficiencies. There'll be a huge defect bilaterally and some sort of a site development strategy. And of course, the last stage being replacement and restoration with a different protocol. And this would be the three phase. Let's say about 2 months for the first phase. Let the soft tissue mature, let it heal, let's get some health in the ridge. Phase 2 being 6 to 8 months of reconstruction and maybe about another 6 months of implant placement, integration, and also transitional and final. Right. So this is easily not unusual to be a 1.5 to 2 year process in order to do it right.
They're one of those cases that you have to emphasize for the patient and his family that we will do the best that we can, but we can just do one miracle at a time. We can do everything all at once.
Exactly, yeah. This is an opposed to the initial treatment that all the miracles were done in one day.
That's correct.
All right, so the phase one, the first thing we have to do is think of a transitional prosthesis, which is not an easy thing to do in a case like this. And I want to get your opinion about, what other options we have. Removing the implants, surgical debridement, removing the bone graft. Now, the bone graft that we talked about apparently was in the soft tissue. It was not really providing any support to the maxilla or the implants, so we have to remove the material in there. First thing that we did was just scan the existing restoration and occlusion. This was just a way of getting a transitional denture made.
Correct. And the tough aspect with that one will be always to capture with the digital scan the soft tissue areas, especially when you want to get, in this case, you cannot do any border molding or capture those areas. So that's going to be always the difficult part to do that we'll need to do intraorally at the time of providing the prosthesis and place the prosthesis on place. But no, it's the best way to go, especially now that we have 3D scanners. Makes so much difference. Intraoral scanning makes a big difference for these cases that are moving all over the place.
Okay, so let's show you the denture again. Okay, so this is just a transitional denture with a palatal support, a minimal flange to provide him some sort of a support in the interim. So the first appointment that we saw him was basically to remove. The removal of the restoration was not very difficult. It was somewhat loose to begin with, but I just sectioned the midline in order to provide some sort of a easier removal of the restorations. But as you can see, the entire complex came out with the implants in the restoration. They were all with fibrous integration and bone loss around them, so it was not terribly difficult to remove. But what was interesting, looking at the construction or the design of this full arch restoration implants, was that it was cemented. And as we can see, there was an exuberant amount of cement all the way around. The implants, the restorations. I know that we can all see there's a lot of problems with this design. We don't have to really get into it, but let's kind of talk about a little bit about any type of restoration, whether it's full transitional or whether it's a final, that this kind of violates your basic rules. What are the basic things you try to look for in a transitional or a final?
Well, you want to have a rigid connection to provide cross-arch stabilization. That's number one. Second one, you want to have clean transitions. You want to avoid any source of contamination or food packing in the area. So here they have just caverns of food packing under an area that is trying to heal.
Yeah, there's just no hygiene.
Nothing is impossible.
Right.
Possible.
So aside from the exuberant amount of cement, it's just unhygienic design, right?
And I imagine that one of the things that they did in this case is that they tried to compensate the lack of accuracy of not doing a convincing guided planning surgery, is that they fabricated the restoration ahead of time, and they left a lot of spacing on top of the abutments. And because they cannot really control the perfect position of the implants, they just fill the gaps with cement.
Right. So, yeah, so we can kind of see this in these views. So following that, there was really an aggressive debridement, removal of the inflammatory granulation tissue and bilaterally in the anterior. As well as removal of some of that bone graft material that was placed supraperiosteally in the soft tissue. And this was something that was very easily palpable in the vestibule, and that's actually on the cheek of the patient. You could feel these globules of bone graft material. And this is kind of what we see here on the right side. This is the material that I was able to find and remove by getting into the supraperiosteal level and try to remove as much as possible. Here's the closure, just irrigation closure, nothing fancy, just let him heal. We want to get some soft tissue health, some bony health, and give him 2 months of healing. And this is him about 2 months.
Do you anticipate any basic grafting in some of those extraction sites, or you just remove what wasn't there and let it
Yeah,
go?
so that's a good question. I mean, there's certainly grafting is needed, but with that amount of infection and the quality of the soft tissue being so bad, any kind of bone augmentation is bound to fail because of the poor vascularity. There's no way to really kind of support any kind of bone graft. So I think it's in the situations like this, when we have aggressive peri-implantitis with a lot of infection, the best thing to do is just remove, wash and clean, and wait. We just have to prepare the patient that we have to cross that bridge another day because we just don't have the vascularity and the soft tissue health to support any type of material. So it's best just to let it mature. It's on antibiotics for about a week, oral rinses, and 2 months later we can have a fairly healthy gingival tissue and architecture.
One excellent idea was to leave the flanges on the vestibule areas very short to prevent any opening of the wounds, any trauma on the cervical sides. I just have palatal support. The patient will need to use a denture adhesive, or be, if possible, even to be without the denture. On this COVID year, that will be fantastic because they will be wearing a mask, so it will not be an aesthetic issue.
And that's one of the challenges in terms of delivering a full denture as a transitional is we don't want coverage because of the hindrance in the healing process, especially if he occludes, he does have an opposing occlusion, and that can only hinder and compromise the healing process. So one of the things that right away it was designed was just the palatal coverage, no buccal flange, and soft reline, and basically I told him, only wear this if necessary. I would rather that you leave it out in the entire time. And he was very compliant with that, and he understood the reason behind it. But there's really no good way to get around that.
Correct.
All right, so about 2 months later, we sat down with him, and he's a relatively young, healthy, social, vibrant person who wanted something better. He said, look, I don't want to live with a denture for the rest of my life. This is the whole reason why I went to have this done, and I want to do this right. So we presented the treatment strategy of phase 2. We informed it that we know that there is bone deficiency, 3-dimensional. And in order to do any type of implant retreatment or revision, we have to develop the site. Vertical, horizontal, and this is what would be necessary. So here's his cone beam CT scan at the 2-month level, 2-month period. We can appreciate that there is, of course, the sinus atrophies. This is unchanged from previous time, but we can appreciate the quite a bit of a horizontal atrophy and thinning in the remainder of the ridge. We do have some bone in the anterior aspect, but the posterior aspect is quite absent. Here's a look at some of the cross sections. Obviously, in the back, we have about maybe 1 millimeter or 2 of height with the sinus pneumatization. In the anterior part, we can appreciate a knife edge ridge, significant amount of horizontal atrophy. This is all the areas where those previous implants were. Things have healed nicely and they're fine. So I think when it comes to prosthetic guided implant dentistry and try to see what type of bone grafting we need, I think it all goes back to what type of prosthesis design do we have?
Correct.
So we stop and think, what is the design? And I think what are our options here? Certainly, one option is removable. You can do several implants with a removable overdenture, which is not what he wanted. So our really focus was more on a fixed approach. So if we were working on doing an all-on-4 approach, perhaps just a pre-maxilla onlay bone graft to correct the horizontal atrophy would be adequate in this case. Just enough to be able to put 4 implants, maybe 2 tilted implants in the posterior. But that's kind of a little risky, especially in somebody like him.
And he already had a lot of failures.
He already had a failure.
And the maxilla tends to be always weaker in the type of bone.
Right.
And so 4 in the maxilla tends to don't be enough.
I would be nervous. I would be concerned.
Nervous.
Yeah.
Especially that he's going to be occluding against a full set of tooth-supported lateral dentition.
Yeah,
so it's not just an
natural teeth,
overdenture.
exactly.
They
So
are
overload.
solid, so you need more to support that maxillary prosthesis that we are planning to fabricate. So all on 4 will not be enough. I
agree
think
with you.
6 will be a very good number to spread that. 6 or more will be always a good option.
Absolutely, and I couldn't agree with you more. I think it's risky, and although it's easy, fast, and cheap, I think it would be another disaster in somebody like him. So, so we have to look at something more all on 6, 7, or 8, depending on the size of the arch. And in that case, we have to commit to not only onlay bone graft in the anterior to restore our horizontal deficiency, but now we need vertical bone in the posterior.
Correct.
And we just don't have the bone to be able to support, even in a tilted format. They're just impossible. So we're going to go with this as our phase 2.
Okay.
The strategy here was to do an onlay bone graft and bilateral sinus lifts to restore our 3-dimensional deficiency, increase our height, width, and develop that. A short video to show the process. This is basically a full thickness submucoperiosteal. Rather large sinus cavities when it comes to its anterior extent. Here's the sinus lift on the right side and the sinus lift on the left side. And we can see that the membrane is intact. We're going to use a combination of some autogenous bone, both particulate bone as well as the ramus bone, using a modified Curie technique, a thin plate of autogenous bone on the buccal aspect to help us to develop the space in those deficient sites, and then use a GBR technique for the rest. This is some of that bone graft material that we talked about earlier that was in the soft tissue. I was able to remove most of it. It turns out there was more left, which I was able to remove at the implant stage later. Here's our bone complex with platelet-rich fibrin. We do our sinus lift bone graft, and we do our GBR for the remainder of the arch, anterior and beyond.
Nice.
Here's our GBR membrane. The critical things, of course, is primary closure. So we have both subperiosteal scoring, as well as using a soft brush to loosen the flap on the buccal, be able to close this primarily with no tension.
Beautiful work.
And here is a couple of slides on the surgical setup and on the bone grafting. And following this, again, the challenge was the transitional prosthesis.
Okay.
If I'm concerned about transitional prosthesis at the last stage, I'm even more concerned at this stage, because any type of pressure from the denture can compromise our incision and the bone graft at this point. So while we had that denture, I told him, "Can you not wear it at all?" He said, "Fine." So we need to have a compliant patient who understands why we're concerned about this type of case, and he was okay with it. So I think that's, it's great to have that when we need to, because the alternative is that we have to soft reline the denture and try to manage it as best as we can, but then we're always concerned about tissue dehiscence and bone graft failure. And
the soft liner will last soft just a fairly short period of time. So we will need to constantly be relying on that to try to maintain close to no pressure on those tissues. So really we have to relieve the denture from any pressure on that area if the patient insists in using that. But luckily in this case, he was super compliant not to use it, and that worked in his favor big time.
Exactly, yeah. So this is just post-op, and once we had the initial healing, and this is at about a 4-week period, I was able to comfortably take his denture and reline and deliver it, knowing that I'm not as concerned about opening of the incisions and compromise to the bone graft. and also relieve the ridge and the buccal aspect, because I don't want any pressure at all on the bone graft itself, because we know that the denture pressure will cause some atrophy and resorption of the bone. So this is purely a palatal support using some adhesives to give him some sense of aesthetics, but not really function.
Correct.
So this was just a soft reline, and we waited about 6 or 7 months of maturation.
Amazing.
So it comes back, and here's our CT at 6-month period. We can see that we have the regenerated bone in bilateral maxillary area. Those are our fixation screws holding the bone graft plate in place. Now we have sufficient width, looking at different sections, and also sufficient height. Here is the area of the anterior maxilla. Now we have this autogenous bone and the GBR, the Curie technique that we talked about earlier. And here is on the right side the sinus lift. So we have certainly developed the foundation that we need to be able to do all on 6, 7, 8, whatever the case requires. And I think it's kind of important that if you're going to do grafting, to develop it as widely as possible. That's our opportunity to build it. Even if we're not sure the number of implants, whether 6, 7, or 8, we know that we need the foundation. So this is the time to really kind of do it as best as we can. And here he is after the complete tissue maturation. He's using the denture with just a palatal stop and the reline, and no function, just mostly for aesthetics.
Correct.
Our phase 3 was to get into the implant replacement and restoration. The fixed implant-supported full arch restoration. Now we're going to follow our digital workflow. Based on the workflow, 7 implants were selected to support the restoration that was designed for his arch size. And I think that's something that's important to consider, the arch size. I mean, how do we decide how many implants? It's not a random number that we decide to do 5, 6, or 7. I think that's a big factor. How do you look at it in terms of the number of implants?
Well, one is what is the final type of prosthesis we're going to be using. The spread of the prosthesis based on where the bone is. We have so wonderful materials on these days that they have certain limitations. When we had the traditional hybrid, which was the titanium framework with a denture teeth acrylic base, we can extend on distal a fairly amount without being worried that the prosthesis is going to break on distal.
Right.
So we can have less implants. But when we have like the new type of prosthesis like zirconia, which is a very strong material on pressure, but the tensile strength is not as good, so they can break if we leave the prosthesis unsupported on distal. So we need to have more implants. And then the thickness of the zirconia bridge, even that they are strong, we need to respect certain aspects of volume, height, and width between the connectors. And
also considering the fact that the grafted bone, we have to consider that it is probably a D4 bone.
Correct.
And in someone like him who has a relatively good musculature and load, this all becomes part of the engineering of the number of implants. So we have to really consider the restoration design, as you mentioned, the type of bone we have, and who is the patient? What is their musculature? What type of load are we anticipating? So these are all, I think, impact the number of implants. And it shouldn't be random. It should be based on those factors. Yeah. So for this, we're going to do a digital workflow, a dual scram process. So we are going to use his existing denture, which had relatively good stability, good lip support, and good occlusion, and use this as our reference. And here he is with the denture. We look at his smile line, lip support, and this is the time to decide whether or not this denture is good or not as a reference, because obviously this was fabricated as more of an emergency-based kind of a transitional, but it may not be right. How do you look for, and what do you look for when it comes to this important phase? Because everything else that we're going to be doing from here on is based on this reference.
Correct. And always, we have to think that full arch restorations on implants are based on the principles of complete dentures. Now, luckily in his case, we have something that we normally don't get with the complete denture, is that he doesn't have a buccal flinch, which really helps us to evaluate the amount of lip support that he will have using this transitional prosthesis during the healing process to evaluate lip support, smile line, midline, cant of the smile, support of the lip, support of the cheeks, on function, at rest, and in occlusion. So we need to evaluate all those ones to really make the decision of if this is adequate to guide the surgery. Even that down the road, we know that we still can modify some of the aesthetics in the porcelain stage. The placement of the implant will be critical at this stage. At least we need to know the overall foundation, location, and geography of the teeth position to have the implants access holes in areas that are going to have a proper thickness.
Right, right. So because we had those relatively good factors from his existing denture with occlusion, cant, lip support, we can use it as our reference. So for this, basically use some fiduciary markers. Here we have 3 markers on the palatal side, 3 markers on the buccal side to be able to use as our references. So for this, just to review the dual scan process for those who are not familiar with it, we take 2 scans with the denture and the markers in the mouth, fully seated. We do a scan, and then we'll do a scan of the prosthesis itself outside of the mouth with just the markers. So basically we have 2 scans, hence the dual scan process. And you can see here that we can see the fiduciary markers both in the mouth as well as on the restoration itself.
With that, just to add that we have to train our staff how to do the scan with the denture in the patient's mouth, because with the mouthpiece, when they bite on it, we tend to dislodge the posterior segment. So very important to remind our staff that they need to have posterior support, cotton rolls, 2x2s, 4x4s, whatever needs to be done if they're going to be biting into that anterior fork to be sure that the denture is fully supported and seated on the back.
So critical. So because I think if the denture is not seated, then of course everything else will be
correct.
wrong.
Correct.
So we have to have good palatal support and seating and verify it before the scan is taken. Super, super important. I think one of the things that we always try to do is do a final reline before this stage to really adapt it well to the tissues, because you get tissue remodeling and the initial reline may not fit anymore. Right. So it's really crucial to do a final reline and absolutely as stable as possible. So our digital workflow is essentially taking the 2 files. We have now 2 scans, and now we're going to merge them together. And we can easily do this on the software. We take the denture with the fiduciary markers, and here we can see the CT scan with the prosthesis in place and the fiduciary markers. Here we can see the palatal aspect of the denture with the markers. And the next step is going to be the merging of the prosthesis itself. Here's the tissue contact area of the denture. And once everything is merged together, we'll have essentially the alignment of the prosthesis with the skeletal aspect. And now we can place our implants We can also place our pins for the fixation of the surgical guide. So here's our workup. Selection of implants, size, width, line, everything is aligned according to the restoration. And we have ample amount of bone to be able to use standard implants. These are mostly 13 millimeter implants in height,
Right.
which is plenty. And here's the design of the implants and also the fixation devices for the surgical guide. And here where we can appreciate the emergence of the 7 implants exactly where we want them. All of these implants are straight implants. They were not tilted because we didn't need to. And that's one of the advantages of developing the bone in the posterior aspect,
Right.
is that we can put straight implants, not having to go to tilted implants and angled abutments. Everything adds in more complexity, more potential issues for errors.
Correct.
I think it's just much easier to work with straight parallel implants than not.
Yeah, we hope all
Especially
the
from a
cases can be like
prosthetist
that.
standpoint, right?
Yes, correct. No, this is an slam dunk.
Here's our pins for fixation. And now we're going to go into the guide design. The guide that is designed here is both a surgical guide and also a reference for the occlusion, to be able to align the surgical guide with the lower arch. Mm-hmm. And so that's what we see here, is that we have the surgical guide that essentially fits into a duplicate of the denture. So essentially it's kind of a male-female attachment. Everything fits together. Then we do a 3D printing right in our laboratory here. It takes about two hours to print this. And here we can see the surgical guide for the implants. And the surgical guide itself fits into a replicate of the denture itself. Because one of the challenges is, how do you orient the surgical guide in a right space? Now, I want to kind of comment on this because this particular surgical guide is not a bone-borne surgical guide. There's 2 different kinds, the one that sits on the soft tissue and the one that sits on the bone-borne. This is not a bone-borne, it is a soft tissue, mm-hmm. Hence we need to have a reference for placement. And we can see that that's verified. Here's the denture in position, and here is the surgical guide with the duplicate of the denture that fits together to make sure that we have the same occlusion, same midline, and same references. And that's the position that the surgical guide is fixated using those pins. For the placement, a standard incision, crestal incision, trying to maintain some of that attached gingiva in the buccal aspect. Mm-hmm. So I think this is critical that we do a palatally based incision, because I know that we're going to need some attached gingiva on the buccal aspect, which we're already deficient. It's not unusual, as you know, Hugo, that with large reconstructive surgeries, we end up with a lot of unattached gingiva on the buccal side. And the reason that happens is because we're using that flap to close over the bone graft, so we're bringing all these attached gingiva to the crest. But we have to at some point put it back or redevelop it. That's probably a concern in the long term when it comes to restoration.
Especially for hygiene, because when you have loose tissue that becomes a foot pack, it's a very unstable environment for the implants to succeed under a prosthesis. So attached tissue is the key.
Exactly. So we try to attempt this by doing a palatally based position flap. Here are the bone graft. This is at about 7 months now. The fixation screws are removed. We can appreciate the quality, the quantity of the bone. Certainly not the quality of it, but the quantity of bone that we have. We remove those fixation pins. The surgical guide is placed in using our reference denture and the opposing occlusion as a way to orient it 3-dimensionally in space. and we use those pins to fixate it onto the maxilla. And then we just follow a complete
protocol
guided implant placement. So the placement of the implants, one of the things that's, I think in this type of case, or any type of grafted case, as we talked about, it's not unusual to have D4 bone with GBR techniques, sinus lift or GBR techniques. So more and more, the preparation of the implant sites are done with osteodensification technique. This was done in this case because it's an opportunity to do a conversion of that D4 to perhaps to a D3 or maybe even a D2 bone by densifying the bone. So instead of drilling the bone out during the preparation, we can actually compact it. So osteodensification using denser burrs is my to-go technique when it comes to site preparation. That also gives me better stability on the implants if we're anticipating a immediate load protocol or immediate restoration. So the implants are placed and the healing abutments are in. We get a closure. And here's the patient after the site healing about 3 months. As we go through the right side, you can see the position of the implants and the maturation of the bone. This is verified through a cone beam CT scan, and we know for sure that we have the thickness, not only from buccal as well as palatal, but also superiorly near the sinus. And the soft tissue is matured very nicely, very diligent about the hygiene and keeping things clean. Now, we selected not to do an immediate load on this patient. Could we have? Probably. But again, you know, it goes back to the conversation we had. Could we have done immediate load? Probably. I mean, certainly splinting 7 implants, you would feel comfortable. And these implants had good stability. But when we shared that with the patient and told him that, look, there's potential for micromotion, even in a full arch, and we could potentially lose an implant or two, he said, no, I'm okay with the denture. I don't need to have it. So I think that's an important conversation to have for the better outcome in the long term. The patient can say, I'll continue to use the denture, and then he was okay not having an immediate fixed prosthesis.
That's a very good idea. I think
what do you think?
It's a tough decision. A lot of people like to really have the feeling of the fixed prosthesis from the beginning. Sometimes the connection of all the implants can help in certain situations to really improve the quality of bone when we don't have prosthesis mobility. That's the key. But if we don't have any issue with the bone quality of the stability of one implant or the occlusion or anything, then we trump all our careful planning and we can have a failure. So to be on the safe side, I think that was a great, smart decision by the patient. It was good.
So here's the implants again. We're happy with the integration. Great soft tissue. We're already developing some emergence even. And after the implant integration, this was allowed to heal for 4 months for integration. Each implant was tested using an ISQ to make sure that we have absolute integration and they all have integrated and healed. And so at this stage, we can go into a load protocol, not an immediate, a delayed load protocol for the transitional. Here are the multi-unit abutments and the posts.
And there was a close tray technique?
Yes. In this case, a wax up was done to really kind of assess, again, the lip line and try to assess his occlusion as a preliminary way to start to do some design for the transitional prosthesis.
And also the prior slide, you had also verification index to verify the accuracy of the implant position, which is
Yes,
also very nice.
Exactly. Very important to have that because that's crucial to have that. So this is the visit where the lip line, smile line, as well as the occlusal line is decided, and the transitional prostheses can be designed. And here's the digital design of the transitional prostheses, which is milled, and it's ready for delivery.
Correct. There was a PMMA, transitional prosthesis, that was done using tie bases on top of those implants.
Yes, and this was PMMA, exactly. So that's delivered to the patient. Again, we can see the lip support, the aesthetic outcome. This is a screw retained at this point. And we let him kind of have this for about a good 3 months. How
Here's a
long
good
do you like to
idea.
wait?
In this case, it's fine. Even that it's not needed to wait that long, it's good for the patient to get used to it, have any minor changes that we can have on the aesthetics, on the amount of display that we want to show, and the patient is to get comfortable with that. I think it's excellent. It's not rushed at this point. The implants are integrated, the tissue. Actually, it's a good thing because if this is going to be a prototype of what is going to be our final design, we can evaluate how good is the hygiene of the patient, if the patient is able to clean under the pontic areas, he's able to clean around the implants, because a lot of times that can be the source of problems. So it helps us to evaluate this. We can modify it, it's plastic, and incorporate those changes into the final prosthesis.
Exactly, yeah. So while we're waiting for him to get used to this transitional prosthesis, final impression is done and prepared for the final restoration. But there was one more challenge, and that's really about the restoration of the zone of keratinized gingiva. The challenges you can see is that the buccal aspect of the implants in some areas is quite thin. In spite of the attempt to do a palatal-based incision to move it more buccally, we have thin keratinized gingiva here. And I think, some may look and say, it's fine. But we like to have thicker gingiva and more attached gingiva if possible.
Correct.
If at all given the opportunity, this is the time to develop it. So at the time when the transitional prosthesis was to be delivered, this is when a vestibuloplasty was done. So what I did was do a supraperiosteal dissection, move the attached gingiva more epically, and fixated it with sutures onto the periosteum, and used a gingival strip technique from the palate. And what this is basically two thin strips from left side and right side where I was able to fixate it to the caudal aspect, the superior aspect of the area, and also some in the middle here. The rest of it was use of collagen material to cover the recipient site. And we know that we have attached gingiva on the palate. Now we have some attached gingiva on the buccal aspect to provide this cellular migration and replacement of this collagen material to restore the attached gingiva. This was really allowed to heal. The transitional prosthesis is delivered, fixed, and the soft tissue is just allowed to heal during that time. And this is the point at about 2 months. Good lip support. Here is the implants with the multi-unit abutments. And we can actually now appreciate the attached gingiva and thicker gingiva on the buccal aspect. We even have some sense of emergence phenomena. Now, unfortunately, because he was still vertically deficient, and this is the PF2 category case, we could not go to a pink-free restoration because that would have been possible if he hadn't lost so much of the vertical bone. As much as we were able to gain, you just can't gain everything. So at some point, we have to have prosthetic gingiva. Here's his final restoration.
In zirconia, all with.
And this is a monolithic zirconia, full arch, screw retained restoration. Again, this is a PF2 case. That's why we need the pink gingiva.
And aesthetically going to look so much better. Even that sometimes the patient doesn't even have a lot of tooth display. I think aesthetically it's pleasant for the restorative clinician, surgeon, and even for the patient. They appreciate when we go the extra mile to make it look proper.
Now, one of the things that you did prior to setting this up, you actually did restore the lower anterior.
That's correct.
Because that was kind of crucial in setting the mandibular plane, occlusal plane. And this is just a conventional bridge?
Well, actually those are individual crowns. These are IMAX, lithium disilicate crowns, but they were layered. So the basic substrate is just IMAX crown that are layered with porcelain. So he was able just to, of course, to floss them, etc., maintaining the temperatures, etc.
Very good. The prosthesis itself is hygienic from the standpoint of being able to have the patient in clean in between and maintenance every 3 to 4 months for evaluation, maintenance, hygiene. Obviously, the crucial part about the longevity of these implants and to avoid peri-implantitis is how to clean around it. What are your concerns about a full arch case? I know that it's designed with that in mind, but what are the things you think about when it comes to longevity of health of the peri-implant tissue?
Well, that's, again, the transitional phase is key. So we can design the prototype. So it gives us an idea how the patient is going to be able to maintain that. Okay. Then I like, at least in our office, the protocol is to bring the patient in the beginning every 2 to 3 months for hygiene to evaluate how is the hygiene at home. And it's a combination of using toothbrushes, proctor brushes, water pick. We even angle and customize toothbrushes so they can clean the palatal lingual areas of the prosthesis. Just give them the tools to try to make it efficient, try to make it easy to maintain at home. And then the evaluation in the office is to verify that everything is properly taken care of using the proper curettes material that are going to protect the implant surfaces.
Yeah. So so he's stored, super happy, tissues are healthy, seem to be very stable, and he was literally in tears to be able to be revised from really a disastrous emotional time in his life to something that is, I think, more predictable and what we think to be stable. I think we have a question here. How long did you keep the transitional in? The transitional we kept in, as we said, for 3 months. Maybe a little bit longer than we needed to, but we just wanted to make sure that he is absolutely comfortable with the occlusion, with the aesthetics, and I think kind of getting used to something that he hadn't had in a very long time. We talked about this earlier, that he was using a denture for many years. And he wasn't dentate before this whole experience. He was using denture and he wanted something better. So it had really been a long time before he had any sense of teeth occlusion or even sense of what fixed teeth are. So I think, giving a little bit of an extra time for the patient to get used to it. And also he gave some feedback about the length of the teeth, about his smile line. We actually ended up doing a little bit of a modification in terms of the anterior smile line and how much he showed in that process. I think it's just a time well spent there's no reason to rush into it. 2 to 3 months, I think, is probably good.
Correct. I will agree with that entirely. In a rush, we tend to have to modify the prosthesis a lot when we are doing the immediate placement at time of, the immediate loading at time of placement. Mm-hmm. That prosthesis we tend to need to modify a lot more because of soft tissue contacts, occlusal contacts. It's not a perfect prosthesis. This was done after proper osseointegration, proper healing time, after achieve keratinized tissue. So this is perfect. And the key word here is this is a prototype of what we're going to be using. Right. So we don't need to rush it. We need to let the patient get used to it. It's not a perfect answer to say wait 3, 6 months, a year. Really doesn't matter. It's, as long as the patient is comfortable and is happy, then we can move forward with the final restoration.
Yeah. Another question is, was there any special diet? I think during the transition phase, we're encouraged to have liquid/soft diet, even though we had integrated implants. Again, with caution about overloading, even during early phases. Again, we're dealing with potentially D4 bone. Even though we have cross-stabilization and it's very stable, it was just recommended to have on a softer diet during that transition, until the funnel was placed. Another question, was there an impacted teeth posteriorly? Yeah, so the answer is yes. He had impacted teeth number 1 and 16 that were there. Because of the thin nature of the maxilla, we discussed considered removal of it, but it didn't really impact at all the bone grafting. And it would have maybe contributed to a significant defect in the back and sinus perforation and things that it would have probably complicated. So
they were properly integrated, and he had been all his life with that. We're talking about a 70-year-old patient that it had been without any problems, and it was not really even close to the area that we are restoring.
Right. No pathology around it. It's
so
had
we can
it all
leave
his
them
life, as long as it's healthy and good. But of course, if the teeth were erupted or if they had any sign of inflammation or pathology, of course, they should be considered to be removed. A question about, do we need a night guard? Good question.
Even there is no history of bruxism, I would recommend to have the night guard. Locally, the patient has opposing tooth-supported prosthesis, so that will help with the proprioception. But still, we're talking about ceramic materials. We're talking about at night possible parafascial habits or any type of trauma that the patient is not aware of, out of control of. So it doesn't hurt to provide a night guard at this point, even if the patient is not a bruxer. I think it just, in the same way that we are over-engineering in the maxilla by having more implants, to over-engineer the protection, I think it makes all the sense.
Right, and I think the follow-up question is the night guard type and also the frequency of the removal for hygiene. So what are your thoughts about removal of the restoration for hygiene purpose? Is this something that you gauge case by case?
That the proper answer. You measure that based on the patient's performance. I always tell them that they're going to come to a test every 3, 4, or 6 months. And if they pass the test with very high marks, then probably want to see them with more time in between hygiene appointments. And if not, we have to see them more often. And even depending on the hygiene, if we see plaque accumulation, sometimes that will dictate that we'll have to remove the prosthesis once a year. I have patients that they have been fantastic with their hygiene. They have been with the prosthesis without being removed for 3 or 5 years, and they do great, and the bone remains.
So it really
I think it's on a one-on-one basis when we are doing those evaluations. And the question about in which arch should the night guard be, that should be. I would suggest just to put it on the upper area where the zirconia is. I think that will be easier to maintain, but it remains also a matter of patient compliance. in my experience, patient tends to comply a lot better when the niger is on the lower arch. But I think in this case, the upper arch is the implant-supported restoration, and in the zirconia, I think we need to protect that area better.
Okay. Maybe a last question. Okay, the question is that did we bury the implants, or was the denture supported by healing abutments? Was that risky? Yeah, so a very good question. The implants had very good primary stability with the healing abutments, so it was done a single stage. And the denture was simply clear.
Resting on top, but not supported by
resting on top of the cuffs, but not supported with the implants.
Correct.
Yeah, and I think the answer to is I think it's safe, especially since the patient is very compliant with the liquid soft diet, and they're really quite well. Again, this case could have been loaded immediately.
Yes.
7 implants, good stability. I think it would have been successful. We just wanted to kind of play a little bit safer. Again, considering where the patient came from, with the level of complication, the last thing we wanted to do is have a failing implant. So call it maybe a zone of comfort, and that's really would be the key there.
Correct.
All right. Well, thank you very much. I think that's all the time we have. Hugo, thank you very much for being here. Not only for your collaboration on the care, but also sharing your thoughts on this complex case. And I couldn't thank you enough. And thank you for all of you for joining us. And look forward to seeing you again next month on complex case discussions. If you have any questions, please shoot us an email. And thank you. Are you happy?
Very happy.
Oh my God! This is the moment we've been waiting for.
Almost 2 years. Yeah, 3
Over
years.
2 years. Wow! Look at that.
It feels like day and night from the. Well, I'm comparing the position and.
Give me some big smile there. Let's see.
Yeah.
All right.
I got my smile and health both back in the old body.
Yeah.
This is a gift from God to you. Cannot compare it to anything else. This is one of the best things that happened to me, with regards to dental work.
Thank you.
I was hoping it turned out to be really good, and it did.
Yeah.
Well, before I came to you, I didn't know you, of course, but when I came back from my trip overseas to the Philippines, I had my dental work done over there. Not that that was my preference, but then because of the economics part of it, I wanted to save money, because the dental work is so much expensive. So I did that. Went to this dentist that claimed to have specialty in dental implant, and I trusted her, and so I subjected myself to the procedure, and the time that it took was like 2 weeks, because I only had 4 weeks altogether spent, over there. So in that span of 2 weeks, she did everything done quickly, from surgery to the prosthetic. Everything was on the rush, and she didn't have the technology that now that I have been to your clinic, that she should have had. She had the CBCT X-ray that she didn't own. There was a lab downstairs that she sent me to get a scan of it, and then she looked at it. But other than that, it's just the regular dental, equipments, but nothing like what you got, the apparatus that you showed to me, the 3D and all that, and other things. And that is why the work that she did was, my wife always calls it a botch job, and it was a botch job. Not only that, I have infection that she didn't know or tell me because she didn't have the equipment to diagnose it and the expertise. Because you have to be an oral surgeon to do this kind of work. You can't just be a graduate person from a dental school and then a few seminars here and there, which I believe she did, because she had some certificates on the wall that she took seminars overseas from Asia to here in the US. And I guess in her mind that made her qualified, and now I know she's not. And many doctors out there are in the same boat, not just overseas, but here as well. Because I've seen so many dentists that I compare you, Dr. Kasmi, to see who's the best. And you are the best. Not just the qualifications, but you went to one of the hospitals in the metropolitan area. I can't remember if it was a
Washington Hospital
Center. You went to the surgery training and all that.
Yes.
I think you were also a team or a head of that.
Yes.
And that speaks volume. Okay? And then the other patients that you have that I look at the website before I made the decision to see you, they are all, I mean, what can I say? These are actual people who went through the process. Okay? And they all said positive things and experienced. Now I know I can share.
How do you love your new teeth after all the...
It feels like it's not an artificial, it's like my same natural teeth. The feel, well, of course, the look, this is next to perfect because my natural teeth is not as good as this.
Yes.
Even many people there, you know, but I'm so happy, the tone, the shade, all that. At my age, I'm a senior citizen. Now, in my case, everything is perfect now. It's now up to me to maintain my hygiene, personal hygiene, and going to the hygienist to get help for the cleaning, because the brushing and the hygiene that we do at home, even with the dental fix, not enough. You have to follow up, like what we talked about, I have to see you. It's like a car, you have to maintain it. Even with the natural teeth, you need to go see the dentist. So I can go to...
What is the first thing you're looking forward to do with your new teeth?
Kiss my wife. Well, thank God, I will pray. And again, of course, I will be praying, but thank God that you helped me.
Thank you.
And I will never forget that. You're the best. And whoever I run into and need some dental work, first thing I will tell them is, don't be a fool like me. Try to save a penny and be a pound fool. You know, at the end of the day, say, put your health first and find the best doctor, surgeon, like Dr. Kasmi, and let him do the magic. That's what I call it. You're sent from heaven to me.
Thank you very much.
You're doing
I'm
the
grateful.
work of God. I already talked to you about that.
We have. Thank you.
And then you're sharing it to the people, the dentist, your expertise, and that's what it's all about. Right? And your crew, what can I say to the crew? Your team. The front desk, from the front desk, everything is perfect. I have all positive experience from day one. Just go to the best right away. Don't worry about the money.
All right. I'll be on that.
Right?
Absolutely.
Okay.
Thank you.
Thank you so much.